as well. So welcome to this webinar participants. We are very confident that as we continue to advance conversation in this regard, in line with the key points the DG has highlighted, we should be better informed and better equipped going into the new year with all our arsenals to ensure that the objectives are properly met and they are addressed. All right, so without further ado, thank you again very much, our Director General, for finding time to be part of this engagement. Let's move on quickly on the next item on this agenda, as we now hear from Dr. Olubunmi Olofa, who will be bringing us what the key objectives, what do we intend to achieve with this particular webinar series, the fourth of its kind, happening on Lassa Fever from the Nigeria Center for Disease Control. Dr. Bumi Olofa, you have the stage, please.
Thank you very much, Mr. Ogoniyi. Permit me to share my screen. Okay.
Yeah, please go ahead.
Okay, thanks.
Presentation mode, please.
Good morning, everyone.
Yeah.
All right, that's fine. Please go ahead.
Okay, good morning, everyone. My name is Olubunmi Olofa. I'm a Deputy Director, Nigeria Center for Disease Control and Prevention. I welcome you all once again to the fourth Lassa Fever webinar series. So I'll be presenting an overview of the objectives of this webinar series. So the theme for today's webinar is empowering communities to combat Lassa Fever. As a way of introduction or background, so I want to remind us that Lassa fever is a viral hemorrhagic disease that is endemic in West African countries, including Nigeria. So it is a significant public health concern with outbreaks occurring every year in the country. Talking about the burden in Nigeria and its impacts, we all know that Lassa fever has been with us for more than 50 years, with cases being reported from almost all the 36 plus the FCT in Nigeria. We can see that currently, in the current week, we have recorded a total of 177 suspected cases, with 43 of them confirmed, and we have lost about 11 of them, unfortunately. So the CFR remains 25.6%, very high. If you remember, the Director General said we hope to maintain a single digit at the CFR. So if we compare the rates we have now and what we had at this time in the year 2022, we can see that we are having more cases than usual. Still on the burden, despite all efforts in the fight against Lassa fever in the past years, the morbidity and mortality keep increasing. So, and this impacts our lives, productivity, resources, and economy negatively. This is actually very worrisome. So the known fact is that the majority of the drivers of Lassa fever transmissions are preventable. They are preventable negative human behaviors, cultural beliefs or practices, misconceptions, misinformation, myths, and other communication issues within the communities. So, and evidence also shows us that we can tackle all this, we can prevent all this. So the question is, what should we do to ensure individuals and communities can protect themselves and loved ones from Lassa fever infection? Also want to know, how do we build and empower communities through effective community engagements? And how do we tailor communication to local context? All of these questions and many other ones will be answered in the course of this webinar today. This webinar aims to contribute to a comprehensive understanding of how communities can autonomously tackle Lassa fever. We want to focus on building resilient communities. We're going to listen to our seasoned speaker from Ondo State, the former state epidemiologist, and who is currently the Director of Public Health for Ondo State. So we're going to tap from his wealth of experience, and we also look at strategies for effective community engagement. We'll be highlighting best practices and key consideration. A seasoned speaker from Breakthrough Action will also talk to us on this. And also, we are looking at localizing communication for Lassa fever, and experts in communication in NCDC will be handling this. And lastly, voices from the field, from the community, a survivor from the community and healthcare worker that has survived the infection will be sharing experience. So we hope to learn from all of this. I want to reemphasize that empowering communities to combat Lassa fever is the theme for this webinar. And let me just join my DG to inform us that together we can build resilient communities, tailor our communication to local context, and engage with communities effectively for a more robust response to Lassa fever. So I invite us to listen to our seasoned speakers for today, who will shed more light on the three highlighted important areas. Thank you.
All right, thank you so very much, Dr. Olofa, for bringing us up to speed with what we are to look forward to in this engagement again today. All right, so time is now. Let's start with the presentations proper, as we now hear from Dr. Stephen Fagbemi, the Director of Public Health and the former state epidemiologist for Ondo State Ministry of Health, who incidentally was also chairman of all state epidemiologists in the country then. He will be bringing forward this presentation, sharing his experience on this topic. Dr. Stephen Fagbemi, you have the conversation. Taking forward. Over to you, sir. Can we confirm we have Dr. Fagbemi on the call?
Mr. Bergen, please, let's move forward with Emmanuel's story while Dr. Fagbemi joins us.
Okay, I can see that there could be some other. By the way, we can understand with Dr. Fagbemi, the state just had transition in government, and there's a new government in power, so that maybe need to still get some things done at that level. But he has assured that he will be on the call, so we look forward to having him join us shortly. All right. Okay, so we have been asked to, I hope I'm not having internet challenges, I'm since connection unstable. Please bear with us if there's any internet fluctuation in network. It is what it is. From one of the survivors of this disease, this is also to let us understand it's not a death sentence. So we have those who have been affected and they have survived it. We'll be having Emmanuel Oluwalanu share with us his experience battling this very disease. Emmanuel, let's hear from you. Over.
Good morning, everyone. My name is Oluwalanu Emmanuel from Ondo State. I am one of the survivors of Lassa fever virus, and I would like to share my story with you all. Yeah, this disease I got this disease from my dad. He was the first person to have it in the family. That happened 2 years ago. 2 years ago, yeah, that was January, after our anniversary in the church. Then we were thinking it's a normal sickness, like it's malaria, typhoid, stuff like that. So we had to call a nurse to our house for the treatment, to treat him, thinking it would be solved easily or treated easily. Then it was after yeah, after the anniversary, he started having this, how do you call it, symptoms. Started seeing some symptoms in him, like body weakness, vomiting, headache, and the like. So there was a particular time during the sickness that he couldn't walk on his feet. We were like, what was the problem? What could be the problem? Though we didn't know what happened then, thinking it's malaria and typhoid fever. So we also prayed. We went spiritual course of my church. We prayed, but no changes, no changes. Then we decided to bring him to the hospital, FMC. So I get into the place. He was given some injections, medicines like that. Though at that particular moment, he was not diagnosed as regard Lassa fever then. So it was there I was with him. Though in the journey, my mom, my dad, and I were together. So I couldn't even separate myself from him. I couldn't even take necessary measures to protect myself, not knowing it's very dangerous. So it was after his death that the results came out that he died of Lassa fever. Then normally I should have gone to the hospital for tests. My mom and I should have gone to the hospital for tests, but we didn't go. It was after the safe burial, because that particular day we were not allowed to open the casket in order not to get the stuff, the Lassa fever virus. So after the burial, it was like, I think a day after the burial, I started feeling somehow body weakness. Though I didn't vomit, I had this headache. I was shaking, high body temperature. So I was like, what could be the problem? Again, that this is not the right time for this. So my brother told me to visit the hospital, that's FMC, for tests to know if it's the particular virus that was affecting me. So when I get to the place, I was taken to a room there for treatment. For tests. I was on the bed. It was after, I think, a day. That was when the test came out that I was having the fever. So I didn't been. We didn't take my dad to the hospital. Probably I could have been dead by now due to the virus, because I wasn't aware at the initial stage. And secondly, it's very important I would like to say it's very important whenever we are having health problems, to go to health centers for tests. And it's not even about prompt health seeking alone. It's also about proper health seeking, because we seek for health care while inviting the nurse to our house, but not effective. That was not the proper one to look for. So I learned that lesson, and since then, in the environment in my community, whenever people are showing some symptoms kind of related to what I experienced, I used to tell them, go to the hospital for treatment, go to the hospital for tests. It is not a thing you can do yourself. But after my case, my mom had the same problem, the same symptom. But due to the fact that I've been confirmed positive of the fever, so quickly we took her to the hospital for proper treatment. And even when the results came out, she was not even surprised, because I was thinking it's the same thing. So after she was treated, I took my brothers, my family to the hospital for tests. They ran the test, but they were negative. The reason why my mom and I were the victim was that we were the one taking my dad to the hospital, places like that. So that was the reason. It's a journey that I can never forget, and I've learned a lot of lessons. I was almost yesterday. I think it was yesterday. Yeah, yesterday we were remembering him. That was 2 years after his death. So I've learned a lot of lessons in my life, and I hope people outside, if they have access to this program, they should take notes of this and be very, very conscious. And whenever awareness is being created on television stations, radio stations, they should regard it. Because there was a time, even before the death of my dad, whenever the awareness being created on television stations, radio stations, I usually discard them, because I usually think it's not our portion, because we happen to be a very neat family. We happen to be a very neat family, so I was not expecting something like that to come. So that's it.
All right. Thank you so very much, Emmanuel Oluwalani, for sharing your thoughts with us. And again, condolences regarding the death of your dad.
Thanks, sir.
It's helpful to know that you've been able to learn great lessons from it. And as you can see, it's of importance to know the very key points you dropped there when you said it's not just to seek prompt care, but to seek prompt and proper care. It could be prompt by calling anybody around or patent medicine vendor and other things. But it's always better when symptoms persist to seek health care at the right place, which is government health facilities. And even at the government health facilities, it's important that people are also informed to know that whenever a condition is not improving, to seek additional support from higher levels of care. All right. Thank you very much, and it's good to hear from you. I hope you continue to stay safe and also continue to be an advocate of this message to everyone around you. It's nice having you on the meeting. Thank you so much.
Thank you very much.
All right. All right. Thank you very much, our distinguished leaders on the call. We now need to move on. I cannot confirm yet if Dr. Fagbemi has joined. Can we confirm that, or we move on to the next item on the agenda?
Dr. Fagbemi has joined, but is an attendee. Can the host please move him to panelist so that we can have...
Okay. No, we cannot afford to have Dr. Fagbemi at the participant here. So let's quickly do that.
So I think I will just suggest let's move on to the next presentation. While we sort out that, because I don't know if they'll be able to quickly do that now.
Actually, I've done that.
Oh, you've done that. Okay, great. Thank you.
Done. All right.
Great. Thank you.
Okay, I forgot to also mention that we have the incident manager for Lassa Fever technical working group and the EOC on the call, and that's been an honor and privilege to have the voice of Dr. Yutunde on the call. Thank you very much. All right, so moving on, we now ready to hear from Dr. Stephen Fagbemi, as earlier introduced, as the Director of Public Health and the immediate past State Epidemiologist on the State Ministry of Health. Dr. Fagbemi, the floor is yours, sir.
Okay, can you hear me?
Loud and clear, sir.
Loud and clear. Okay, good morning, everybody, and thanks for this opportunity to be able to be a part of this. I think it's very strategic, and I believe that it will change, it will bring some positive changes. I want to congratulate the DG. I listened to his presentation, his discussion on channels this morning, and I believe it brought more clarity to the Lassa Fever EU. So can I share my screen?
Please go ahead, sir. I think it's better.
Okay.
So while Dr. Fagbemi is sharing the screen, for the participants on the call, please let's make sure we use the relevant boxes to put our questions, the Q&A box to put all our questions as we go on with this presentation, so that at the end, we'll be able to collate and address them appropriately. Let's not forget, let's use the Q&A, not the chat box, the Q&A box to drop all our questions. Thank you very much. Dr. Fagbemi, please go ahead.
Okay, thank you. Can you see it?
Yeah, clear, sir.
So yes, I'm just talking on how what our experiences have been and how we can build resilience, and deepen community and personal involvement around the Lassa fever use. I believe the last speaker has shared the personal stories, and I always like to remind everybody involved in Lassa fever that to some people it is just data, to some people it is numbers, but to some people it is lives. And so it's real. So, in those states, we have clearly organized communities, towns. We define structures along traditional, socio-cultural, and political lines. Our communities are well organized, and all these things are in place. And I believe we've leveraged on that over the years. We've been at this battle for Lassa fever for many decades, but in the last 10 years, it has been intense. A lot has been done around the community engagement, risk communication, and we've used almost all the platforms that are available. The outbreak started from rural communities several years ago. It has moved to semi-rural communities and a few urban cities. And all the traditional and political stakeholders there, they have been extensively engaged, both at the individual level, street level, the PHC ward system, as well as the local government, and of course, at the state level itself. And we've had all our partners collaborate with us very well. And almost all our interventions require and depend on community involvement. So we've been doing that, and whatever little success we've had, we couldn't have achieved without community involvement. So what have been our success stories? Several community outreaches, every year in, year out, we do them. We do street campaigns, we do road shows, we do market outreach, church outreach, motorized jingle campaign. We've gone to mosques, we've knocked on door to door. We've done several of these. We've also gone ahead to do the rat eradication campaign, launched at the state level, moved to the local government headquarters, and even at the community level. We've engaged the traditional rulers. We've had kings call all the chieftains, the fiefdoms together to talk about this issue. We've done a lot of that. We've walked through some religious leaders. We've walked through unions, associations. We've engaged them robustly. And of course, we've also worked with the survivors, Lassa champions. We call them Lassa champions. We've used them extensively for surveillance activities and for risk communication. Some communities, they've been very helpful. So these have been our success stories, and apart from of course, the usual mass media campaign that is almost ongoing all year round. Now, what results we have achieved is because of these established traditional and social structures. The kings in many of the communities that are affected have taken this very personal, and they are really deeply concerned about it. So, and the dialogue continues. We've had times of difficulties, but the dialogue continues. And then we continue to work with the patients and the relatives, and we've had support from partners. So let's go to what's the SWOT analysis. I was told that I needed to talk around this, and perhaps this is important. So our strength, like I said, is the organized community structures, and then the support that we've had from partners and the subsidy we've had in terms of care for the patient. We also have a lot of trained human resources. Having battled this virus for decades, you can imagine the capacity we have, in terms of experience and expertise, and of course, the partner support. But the weaknesses are huge. There is, even though we have these organized community structures, we have the leadership we talk about, but there's a social change taking place in Nigeria. And Ondo State is not an exception. They are questioning the legitimacy of this leadership. all these traditional leaders and religious leaders, they don't they don't command the respect they used to command because of this social disenchantment, So that has become an issue when we continue to use them. People are doubting whether it's not just for money, whether they are not gaining. The government distrust has trickled down to all these levels of leadership, and it's affecting risk communication activities. And when you ask people to gather together now, they don't trust you. They don't know what exactly you are doing. Secondly is the weakness of the primary healthcare system. The primary healthcare system, and I'm glad that the DG was talking about this, is supposed to be closest to the community, to the individual, where they can get help, medical attention. But even if they cannot give the needed attention at that level, they can give them appropriate information. But the PAC system is very, very weak and very, very porous, especially in the rural areas. And we should not run away from that fact. And because of that, that level of expertise and factual information that's required at that low level is not always available. There is also high level of illiteracy. Now, please take this with a pinch of salt. People do go to school, but what do they really learn in school? You've seen professors behaving as if they never went to school. People have gone to school, but when it comes to healthcare behavior, sometimes you doubt whether they've been inside a classroom at all. So this is affecting, because we felt education should change behavior. But in some part of Ondo State, you would think you are in part of the world where there have never been schools at all, the way people behave. So we have to collaborate with the education system to make sure that people go to school and they are enlightened. Now, there is low risk perception. In fact, it's getting lower and lower and lower because of the transition of the epidemiology of the disease. People are no longer as bothered as they used to be. They can care less. And because, again, we have faced several pandemics, the COVID-19 pandemic has just blown people's mind away. They don't care anymore about any other thing. So, and that is affecting the response we are getting from the community. And of course, the inducement that we have been given as a public health strategy in Nigeria is now becoming counterproductive, because every time you give inducement, you motivate people. Now that there are no inducements, people are not ready to listen. If you call people together for a community engagement now, they will ask you whether you are ready to pay them. And once you are not ready, they won't come or they won't listen. So it's becoming an issue now. We must find other ways and not just throwing funds, down the drain. And the lack of indigenization of ideas. I believe in our traditional philosophy and orientation. There are quite a lot of things we can tap from it. But the way we have, well, not everything, but largely from the beginning, Lassa fever was being managed as if it was a white man disease that originated in a white man's land. And we use white man's language, terminology, and white man methodology. And that has created a kind of disconnect. This is important as it spreads around the country. We must take care to know that we must customize this thing adapt it, and look at what are the indigenous initiatives, ideas, and knowledge about these things. This has given us a challenge. Opportunities. Well, the opportunities that we have has always been the training we have. And I must say, opportunities around, even the pandemic that come has also helped to shore up our capacities. So in that sense, we can say it has been an opportunity, and all the intervention we've had from the various programs have been an opportunity for us. But what has been the threats? Of course, security. The Lassa fever in Ondo State is endemic in 5 local governments. And out of that 5, 2 are highly security compromised. And in fact, nobody can say precisely what is the real prevalence, the burden of the disease in those areas because of the security compromises that are there. Partners cannot go, and even we go with fear. I'm sure you are aware that even traditional rulers have been killed and kidnapped in those places. So when they kidnap a whole traditional ruler in an area, so what do you think strangers will do? So this is a very huge challenge for us. And then the manpower shortage now, this emigration is really an issue. A lot of people that have been trained, they've left the system. So we have a lot of manpower issue. And finally, health workers' attitude. The health workers, their attitude is becoming more and more negative and hostile. And so patients are not willing to come to the healthcare until things nearly get out of hand. And even those who are coming, they are insisting that they must leave within a few days. So these are issues around how we train our health workers, how we motivate them, and how we make sure that they are more humane in their treatment of patients. So what are our recommendations for moving forward? We believe that what is happening now, the NCDC-led initiative, along with others, is good, that there must be deeper engagement. We are glad for the HCD program that took place over the last 18 months, that we should listen to the community, not just think for them, but we should listen to what they are thinking and what are their fears and concerns or lack of it for this disease. We should explore sociocultural methodology. Increasingly, alternative care is becoming more and more prominent in many rural areas. And even the rich can no longer access the orthodox care settings. And rather than alienate them, we should work with them. If patients continue to go there, we should work with them. And I think it's important we do that. We must empower the PHC system. The PHC system is the foundation of our healthcare service. As long as it remains weak, there is nothing we can build on it. Epidemic-prone diseases are not, they are different. Unlike non-communicable diseases where you need sophisticated gadgets to tackle, epidemic-prone diseases are common everyday disease that our life and livelihoods is what drives it, and it's at the primary healthcare level we must deal with it. So it's important, and the PHC system puts the power and the control in the hands of the community, not bureaucrats, not experts that sit in ivory towers. If we don't get it right, we'll continue to just walk a dark path. I talked about indigenization of ideas as what we also need to do. Scaremongering is not going to work. That you have Lassa, you are going to die and all of that. That's not working anymore. Of course, they have suspected that they will not die the way we think they will die. But we can discuss around other issues. We can talk about the costs in terms of their livelihoods, even though not in terms of their life. And a few other things that I think can work, and especially as more patients are getting infected. Then the issue of waste management is a big problem. The rats are there, they are spreading. Waste management is a big challenge in those states. And those of you who are in the news will see that even the new governor, the governor now, is concerned about it. It has always been a challenge. We are not sure whether the government has capacity to deal with it alone. So we are thinking local initiatives around waste management we should start working around it. At the international conference, the first international conference on Lassa fever, many of these ideas were muted, but it never took, it didn't gain traction. Building local incinerators, dump waste to wealth, composite sites, and all these things. These are things that were well canvassed at that international conference. And some of us are looking forward to the next international conference and see what other people are doing in other parts of West Africa. Then empowerment of environmental health officer. Nigeria will continue to suffer afflictions of all these communicable diseases if the environmental health officers who are supposed to do their job, be on the ground, do the beats at the street and ward level are not empowered. It's not enough to recruit them, but they must be given the tools to work. They must be empowered to go around to monitor compliance. All the rules and regulations about sun drying, about waste, about this and that. But is it the doctors and the nurses in the hospital that will empower it? No, the enforcement is environmental health officers. So the country needs to look at the role of environmental health officers strategically if we must deal with all this, and then we need to change the orientation of the message to reflect new realities. This virus is behaving strangely from what it used to do decades ago. And our message must also adapt, as the scientist gives us new information. We talk a lot about personal and food hygiene. I was glad that the DG mentioned it extensively. Food hygiene, and this is something that can be dealt with even at the local level. So local food production, food processing, some of the things that all these agri development industries can work with people. These are things we need to do. And we believe that doing that. And then lastly, intensify use of social media. Social media has come to stay, and people believe more in it now than even in the former channels. And I think we should be more active on the social media too. And the use of religious icon, even though earlier on I said that some of the trust factor in some of these leadership structures is not there. But you'd be amazed that there are key religious personalities in Nigeria that wield huge influence. When they speak, it's as if God has spoken. In fact, they are more powerful than God, actually. And I say that with all sense of responsibility as a religious leader of high repute myself. And so we can key into that. And if they speak and people are ready to listen to them, why not we work with them and let them speak the right things? And also, again, entertainment icons, And I'm happy that we have a drama going on now. I think the Nollywood should work more around that. We should have feature films on Lassa, both in the English version and in all the other, the Igbo Nollywood and the Yoruba Nollywood. And these are the things we need to work with. And NCDC must take this head on. We are not talking of some low budget films. We are talking of the ones that will really, like the October one, like the one around Ebola, the one that will really catch the attention of people. Talking all these human angle stories we are hearing, people need to watch it for real and see what evil the Lassa fever virus really is for what it is. So these are some of our recommendations. Once we have the resources to do, we will do. Others we will leave. I want to thank you for this opportunity, sirs and ma'ams.
Thank you so very much, Dr. Stephen Fagbemi. It's always interesting and enlightening hearing from you anytime, whether formally or informally, with such a wealth of experience you brought into the conversation and engagement this morning. A lot has been said. We're taking notes. We're going to come up with some other summaries towards the end. But now we are really doing well, fairly with time, so we need to improve on that as we go on to the next item. So I want to know, Dr. Fagbemi, if you need to dash out for another meeting and come in, there will be question sections at the end, so that we will be made available. I mean, you will be available to be able to attend to them moving forward.
No, I'm sitting in throughout.
Oh, excellent. Thank you so very much, sir. We appreciate that. All right, so colleagues, distinguished leaders on the call, please let's continue to keep our questions as we have them in the Q&A box. As we go to the next presenter now, we'll be looking at strategies now for effective community engagement, some of the things that have been mentioned, and how do we highlight the best practices and key considerations in this regard. Taking us further on this conversation, please let's make welcome the Deputy Project Director, the Risk Communication and Community Engagement for Breakthrough Action Nigeria, one of the critical partners on risk communication intervention and other areas in the country. Dr. Olayinka Umar Farouk, you have the floor, please.
Thank you, Biadu. Dr. Fagbemi, please, can you stop sharing?
That's what I'm trying to do. Oh my goodness. I'm trying to find out where I should do that. Okay.
Okay, thank you.
Yeah.
Good morning.
Is it okay?
Yeah, we're fine. We're fine. Dr. Olayinka is sharing his screen now, so I'm your screen, so let's go on with that.
Okay, so good morning, everyone, and thank you for the opportunity to share strategies for effective risk community engagement. I'm going to, my presentation will be in 3 parts, one around the strategies, then I'll go into experience sharing and some considerations when you're looking at best practices. I appreciate Dr. Fagbemi's presentation because it kind of set the tone for my presentation. So when we look at community engagement, what exactly does this mean? So WHO defines it as a process of developing relationship that enables stakeholders to work together to address health-related issues and promote well-being to achieve positive health impact and outcome. So key thing here is community engagement is a process. You need to work together, and you must have a goal in mind, which is again positive health impact and outcome. When we talk about community and community engagement, we are not talking about the geographical locations alone. We're looking at social identity, religious communities, again, people that have shared interests, so for example, at-risk population. The goal of any effective community engagement is empowerment. And you must have, what are you empowering towards? Change in behavior, change in the environment, policies, practices. Riding on what Dr. Fagbemi said, do you understand? There's a whole lot needing to focus Lassa fever management on waste, on looking at waste, environmental sanitation, and building of what the DG also said this morning. So why is it important to engage the communities? The DG elucidated many when he gave his opening remarks. Most of them are not here. I focus mainly around the communities, which is really, for any public health intervention, we need to focus on people-centered care, people-centered communication, adaptive communication. So people remains at the heart of public health intervention. We know that the actions taken or not taken can mar or make an outbreak or a public health event. So not washing your hands, again, practicing your cough etiquette, it has potentials for, again, accelerating or reducing the outbreak. We need to understand that right to information is human right. People need to know about the risks they are facing to their health and well-being. So information must be passed and in the appropriate channel, in the appropriate language that meets the needs of your audience. Culturally, okay. And then when communities are effectively engaged, which I will show you some of our examples, they're able to generate local solutions to problems. And in the act of effective engagement, you are able to build capacity so that they can further be empowered to identify their issues and their needs. There's different models of community engagement. I've listed 4, and I'm just going to browse through it. Self-determination theory. If my basic human needs have not been satisfied, there's no way you will be able to motivate me. And so going into, again, the incentives that Dr. Fagbemi alluded to. So if you have good roads, good water, access to health care, again, those incentives won't matter. And so we see a whole lot of community engagement moving towards self-determination theory. We think through the behavior change ball and looking at, okay, who can we use to get to the next person? And we see this kind of engagement also there. So we have focusing so much on the religious leaders and expect that whatever they say, everybody listens. So that's behavior change ball. I will deep dive into community-based system dynamics, sharing the experience of breakthrough action. This uses group model building and aims to facilitate teamwork, identify participants through gatekeeper, and truly engage the community in solving their problems using participatory action. And as we move forward, again, most research, people are looking at participatory action research. The human-centered design approach that we also use is one of the ways you look at participatory action research. The spectrum of community engagement, there are 5 levels. The first level is inform. When you are informing people, it's a one-directional communication. And you focus on what the people should know and act on. The purpose of this is just tell, broadcast information. And we do this a lot through, again, fact sheet, advisory, website, outreaches, newsletter, but just telling. The next step when you're engaging community is consult. Okay. And in this way, you are listening to them, seeking their input or feedback. You want to understand some of the things. So you look at when people go in to say, oh, we're doing town hall meetings, we're doing surveys, just to understand the community perspective better. So you're consulting. The third stage of community engagement is involved. At this point in time, there's now a two-way communication that has been established. You now want to work with the community to understand the issues better. So you do this through community dialogues. Again, if you're doing a research, they form part of the design, data collection, workshops. The fourth level of community engagement is collaborate. And if you notice, my icons keep on changing. So from the first one, one way direction, inform, the consult, again, they are telling you what more, providing you more information. Involve is two-way. And collaborate, there's a kind of networking. So you're partnering with the community and you're seeking advice and innovating together. You have meaningful partnership at this stage. You are building consensus, you are co-designing, you're working together. And the highest form of community engagement is empowerment. At that point in time, the communities are at the driver's seat. They are the implementers. They know what needs to be done. At this point, there's shared leadership. At this point, they have taken on ownership. They make the decisions related to their communities. So 5 levels of community engagement. Majority of the interventions that we do stop at, again, probably at involved stage. The collaboration needs to be a bottom-top approach. And I will share experience. So general principles when you're looking at community engagement is your goal is to be able to build trust, empower the communities to be resilient. And in doing that, you need to have some of these principles at the back of your mind. You need to respect the community's identity and diversity. We all different, even twins, they differ. You need to make sure that you leave no one behind. There must be transparency, open, honest conversations. The goal is on partnership and collaboration. You need to be flexible. Your timeline, you go in today and they're not ready for you, doesn't mean you relent. You have to be flexible and understand and contextualize to their needs and the wants. You need to be accountable. And if community engagement goes as it is, in the way it's supposed to be, there'll be a whole lot of capacity building. There'll be localized communication. The community will see the benefit, and there's a need to continue, evaluate, and learn. So I'm going to share the experience of Breakthrough Action. Breakthrough Action is a social and behavior change project. Our goal is to ignite collective action, and we do community engagement, working with diverse stakeholders, from healthcare workers to religious leaders to women groups. But I'm focusing on WDCs, the World Development Committee, and using another intervention, maternal newborn child health, to explain and show results on effective community engagement. We've started the same process on Lassa Fever, but I'm focusing on MNCH. So what's the WDC? They are the smallest unit of governance in Nigeria. There's a constitution that recognizes them. The National Primary Healthcare Agency identified them and have developed an operational guidelines that recognizes them as a way to strengthen the World Health System. They have the responsibility to organize and manage health and development activities within their wards. They are individuals within the community that are selected by the community. There's a guideline that shows what the composition of a WDC should be. So going to, for Breakthrough Action, we use what we call the Community Action Circle, okay? It's a process of collective dialogue and action-based planning. and allows the community to identify and make the change that needs to happen. It has 7 steps, and I'm going to be explaining each step. So step 1, prepare to mobilize. In prepare to mobilize, you look at what do you want to do? Why do you want to do it? You're kind of like answering like the 5 W's and H. What is the issue? For colleagues here who work on the maternal newborn child health sector, we know Nigeria carries number 2 across the world. Again, second in the world for highest maternal mortality, highest second also for newborn mortality. When you look at the National Demographic Health Survey and comparing trends, this was 2023, 2003, 2008, 2013. Approximately 160 women, pregnant women and in postpartum period died daily in Nigeria. 718 newborns die daily in Nigeria. 2,700 under 5 die daily in Nigeria. And then you ask yourself, what do you need to do? Where do you need to do it? And what's the change you need to? So as a project, we identified the WDCs, the World Development Committee, as an agent of change that can support in helping to improve maternal newborn child health. And we worked with a vision in mind, seeing how communities come together to take action. So prepare to mobilize. So you look at your data, what is it telling you? And then you look at where is most affected and where can change happen. In looking at where is most affected, we worked in 5 states. So Kebbi and Sokoto, over 90% of deliveries happen at home. If you are doing an intervention that is in the facility, you will not reach your population. 9 out of 10 deliveries in Kebbi and Sokoto take place at home. So what do you need to do? Step 2, you organize the community for action. We identified the WDC. There's an operational guideline that tells you how they need to be formed and operate. So I'm also linking my presentation with the 5 levels of community engagement. So at step 2, the purpose is to inform, and here you clarify the purpose. What do you want to do? So at this point, what we did was community entry, community mapping, and then reactivation. So community entry, going into the communities after using data to identify which communities are most affected that will benefit from this kind of change. You map the stakeholders, and then you're using WDCs. You look at, okay, what's your current constitution? The WDC charter mandates 40% representation by women. So that needs to be on board to have the right composition. So that's what you do when you're organizing for action. Step 3, this is in alliance with consult. So you're going to explore the health issues and set priorities. The purpose at this point in time is to listen to the community. You need to understand their culture, perception, economic conditions, again, the whole gamut of what is important to this community. So you do focus group discussion. A key one we did was the human-centered design, formative assessment, and where we spoke to over 300 people across, more than 300 if I count FCT and Neboing, and just to better understand the issues. And we're able to identify why people don't use the facility, the role community leaders play, the role women did not have the agency to take up their own health issues. When you understand the issues better, again, not using just the numbers that were in the NDHS, but also hearing from the communities, observing them, seeing them act. Again, observation is very key. You're able to start piecing the puzzle together to identify what can we do together. So in identifying what can we do together, we went to work with the communities to using problem 3. You can see this is their own problem 3. It doesn't have to be highfalutin like the ones we know, but they need to understand, oh, again, this is what we see, what can be the root cause, and then identifying the solutions themselves. In some instances, we do what we call a storyboard, where you tell a story, a pictorial story of the beginning to the end of the disease, and so that they can better understand it. Because again, you need to understand the level of the literacy level of your audience, and then bring the information to a way they can understand. Then the next step is you do a prioritization matrix. Let them prioritize what they want, the solutions, what they want to do in their communities. Step 4, which is also involved. At this point, you're involving the community to go design the solution. So you work together, workshops, they've understand, they've prioritized. The next thing is, what can you do? So each community, each ward development committee developed what we call a community health action resource plan, which gives them the objective, again, the resources they need, the activities, the unit of measure, and they've developed it themselves. They also worked with their facilities to identify, again, community health information board. What indicators do we want to track to show how we're making progress in our community? Then we move to step 5, which is collaborate in the levels of community engagement. Now you mobilize the community for action, and you allow the community-led approach. So from compound meetings, to town hall meetings, to sensitizations, to playing games, to again, community dramas, we acted together based on what they have identified as what they would do in their community health action plan. We were monitoring, providing on-the-job supportive supervision, and building capacity, organizational capacity, leadership capacity, again, team management, resource mobilization, all as part of the package, and helping them to move just beyond the health area to empowering them. And then level 6, which is around empowerment, we evaluate together. We look at, okay, how have we been able to allow communities to make decisions on their own? So we have monthly or bi-monthly review meeting. We've done experience sharing, rewards and recognition, peer mentoring. This was one of the key successes, where a WDC in another ward goes to another location to help his peers and say, okay, what's your issue? This is how we've done it. So peer mentoring, evaluating together. So how have communities taken action based on our own findings? We've worked with 230 WDCs across 5 states. Something like Bauchi, based on their CHAP, their implementation rate is about 93%, Sokoto 49%. The WDCs have transported almost 100,000 people to the facility using their own vehicles, working with NURTW, transported pregnant women, taking women for delivering, children for immunization, and even the general public. They have raised almost 50 million by themselves. This implementation started in, I think, October 2020. They have supported over 75,000 children to get their first dose. Again, majority of births occur at home in this community. So apart from the hospital, again, indicators, what else have they done? This is WDC in Kuntuku. Perhaps nutrition, malnourished children was more in their community. They have produced Barbara nut, Tom Brown for themselves, and they are selling. WDC in Gwagalada quarters, they donated prepaid meter to their facility and built borehole. WDC in Dobi provides drugs and sanitation materials for their facility. The one in supporting Amechi PHC, they call the mechanic to repair their tricycle ambulance. And again, level of empowerment, they themselves have seen themselves as leaders. They have developed ID cards for themselves, their own letterhead to be able to again write to different community members or philanthropists to support. They continue to track their community health information board, and have even gone ahead. The WDC in Kwali, they provided scholarship to some orphans. And that's what, again, that's how communities take action. So It's a process. It's not a one-off experience. It's not an outreach. It's not community engagement. So when you finish, again, going back to step 7, prepare to scale up. And then you prepare to scale up or you repeat the process. You go back to organize your community based on this. So we scaled up in some places we didn't scale up based on the context of each WDC. So what am I saying in summary? Community engagement is a process and an outcome. You will see the outcome if you invest in the process. We need to recognize communities as experts and key to building resilience and driving ownership. Engaging communities through a participatory process, we need to move away from to focusing more on collaboration and involvement. So move away from inform and consult to more of involve, collaborate, and empower. Every community is unique with its own challenge and capacity. The same approach cannot be for all. We need to be gender sensitive and context specific. We need to throw away the box. And I ask people, the same community leader or religious leader that you engaged for the last outbreak, are you telling him something different? Why can't we just look who else needs to be here? We can't continue to do the same thing the same way and expect a different result. We must actively listen and observe and aim for intrinsic motivation. It's going to take a while. Behavior change takes a while. Data should drive our engagement, but it's not just about the numbers. You must understand the perception, the attitudes, behavior that drive this. And if you're not tackling it, we're not going to see any difference. I would say, again, this might get me well. Don't tell people what they need to do. If knowledge has never translated into action. People must think, feel, and do. Whatever information you're passing us must appeal not just to the head, to the heart, but to the feet to take action. So it's not just about passing on information. If that information has not resulted in a change, then you have not effectively communicated. Lastly, we build trust by treating communities and partners. A community that is engaged and working together can be a powerful force. I hope I have been able to show that with the experience of Breakthrough Action. Thank you so much. Back to you.
Absolutely. Thank you so very much, Dr. Laika Umar Farouk, for doing justice to these, coming from the perspective of what the contribution of the private sector, the partners and the private sector engagement has been in this regard. You've dwelt in a lot of key issues, which I believe are take-home points increasing in this conversation, helping us to understand the expertise that reside in the communities, and that we cannot see every community as the same. So it's not a one message for all or one size fits all approach. And that we also endeavor to listen and observe this intrinsic motivation and information that could help change the narrative of the way we do things, so we can do it differently and we can get a better results in the years ahead. Thank you so very much. Again, a lot of conversation has been raised in the chat box. Please endeavor to put yours in the question and answer box. That's the Q&A box. If there are things you would want us to answer as question. But I appreciate the conversation so far. In the interest of time, let's move on as we now take the next presentation, and that will be, I'm thinking maybe we take all the presentation before we have the voice, but let's just follow the agenda so that we can have a senior registrar from Abubakar Tafawa Balewa University Teaching Hospital, Bauchi, in Bauchi State, who is also a Lassa Fever survivor. I read also on the chat box that we also have another survivor on the call, on this webinar, who happens to be a nurse also. And this tells us how this infection spread and the risk our healthcare workers are really exposed to. But let's hear quickly from Dr. Jamila Sulaiman Rififa, who will be sharing our experience, very, very, very great one, on how she battled and survived Lassa Fever. Dr. Jamila, you have the floor, please.
Well, thank you, Mr. Biodun, for that introduction. Good morning, everyone. I'm Dr. Jamila Suleiman Richifa, as earlier introduced. I'm a senior registrar from Department of Obstetrics and Gynecology, Abubakar Tafawa Balewa University Teaching Hospital, Bauchi. Well, I want to share my Lassa fever experience as a healthcare worker, which forms a great part of one of the communities that helps in the curtailing of the Lassa fever virus, and also can serve as a form of spread of the Lassa fever virus. My story dates back to 2014, while I was a junior doctor serving at the Abubakar Tafawa Balewa University Teaching Hospital at the Accident and Emergency. So a patient presented with symptoms that were more of suggestive of meningitis. The patient was unconscious. The point there is that I saw the patient without using my personal protective equipment. So after seeing the patient, I came down with fever, diarrhea, and vomiting after about 2 days, for which normal I was treated like the normal routine malaria and typhoid, but I was not responding to the medication. So that was in a private hospital. Most of the times when we get sick, we don't usually go to the tertiary centers. We visit small hospitals before we go to the tertiary facilities. So same thing happened to me. Then later the fever was not coming down. I was transferred back to the Abubakar Tafawa Balewa University Teaching Hospital, Bauchi, where still I was being treated as a case of gram-negative sepsis. There still the index of suspicion was not there until we lost that patient that I saw after he has started bleeding from the nose, and then we got also a history that his daughter passed away 2 weeks prior to his illness from a similar condition. So then sample was taken in before the patient died. My sample was all taken. But at that time, we didn't have any laboratory within the Bauchi metropolis, so it had to be sent to Irua Specialist Teaching Hospital. And still, it is cause of delay again for the diagnosis of the condition. Prior to the return of the result for the Lassa fever PCR, I developed symptoms that suggested acute abdomen, so I had a surgical intervention. So that was, I think, the hallmark of the disease, because I bled from the operation sites, I was bleeding from the catheter, and then also the drain that was passed through, I was bleeding. So I was admitted into the ICU intensive care unit. At a point, I lost consciousness. I was there for about 9 days. I had 9 units of blood transfused because of the bleeding I was having. And lo and behold, the result came back positive. So what are the lessons I want us to learn from this story of mine? Because it's not just sharing the story, but there are some key points that I want us to take home today. One is effective and correct use of personal protective equipment. Because when I saw that patient, I saw the patient like just a normal patient. I didn't consider that patient to be potentially infectious. So all healthcare workers should see every patient as a potentially infective patient, and hence we should use our personal protective equipment. The lowest being the use of hand gloves and then face masks. Then secondly, the index of suspicion was not there, because I was being treated as a case of malaria, typhoid, again, back to sepsis, I had surgical intervention. So until we lost the patient before the suspicion was heightened, and lo and behold, it turned out to be Lassa fever. Then thirdly, provision of facilities for early diagnosis and treatment. I want to share that now currently in Bauchi, we have a molecular lab. We're able to make the diagnosis of Lassa fever within 24 hours of suspicion. So any patient that presents to our facility, we have a holding room for the patient. Once the suspicion is made, the patient will be kept there, and the samples will be taken and sent to the lab. And within 24 hours, we get the result, and then we continue management. If positive, we move the patient to the isolation center, and then if negative, the patient will be transferred back to the ward. So thank you very much, everyone. I hope we've learned some lessons from my story. Thank you very much.
All right, thank you so very much, Dr. Jamila, for walking us through this, and thank God for your life. It's good that you're still alive to share this and the lessons learned. I believe has really informed a lot of change in the way you do the work going forward and how you also advocate among other healthcare providers. We cannot afford to lose any of our healthcare workers the same way every life matters to us as a country. And at the Nigeria Center for Disease Control, this is what we are committed to, protecting the health of all Nigerians. All right, moving on in this engagement as we begin to bring this conversation now to a wrap, and addressing the questions that have come up on key issues in the interest of time. Now it's my opportunity and privilege now left to welcome the Head of Risk Communication and Community Engagement at the Nigeria Center for Disease Control, Dr. Yahaya Disu, who will be taking us through the topic, localizing communication for Lassa fever. What do we need to know? Dr. Disu, let's get it on.
Okay, thank you, Mr. Moderator, and good afternoon, DG in absentia, and directors, deputy directors, and all the participants. I remain on the existing protocol. So I'm just going to lay out.
Dr. Disu, if you could get this on the slideshow or presentation mode.
Okay, I'm trying to do that. Let me see if it responds. Okay, so I'm waiting for it to, okay, yeah. So what I will be talking about is, my job is very simple. Every other person who has presented earlier, starting from DG, they laid the foundation, particularly the last presentation, Dr. Olayinka, and leveraging or layering on what Dr. Fagbemi presented on the experience in the community. So my focus will be on the audience because we want to localize our communication. And what does it mean to localize communication? And it's actually a process of adapting our message to meet the local context. And the local context of the audience in this regard refers to the culture, the history, the preferences, the customs, tone, and other requirements of the target audience. And then you can see in the diagram on the right side, and that encapsulates those things, even including the emotional values and so on and so forth. This is what makes us human. And we must respect and recognize this if we want to make our communication to be very effective, irrespective of the community engagement strategy we are applying. But this time around, we're talking to individuals, talking to their humanity. This helps us to ensure that our messages are not just understood, but also they resonate with the target audience. It's something they can easily recall. It's something they can easily recall, something that is memorable, something that is impactful, something that they can want to discuss with other people. And then it is also essential for creating awareness and influencing behavior change. That is the essence of what we want to do. We create awareness so that people can have understanding of the situation. And also, and then they also take informed actions. This rests on trust and loyalty. So whatever we're doing, if people don't have our trust, then we will be having serious issues. I remember during the COVID-19 pandemic, at the peak of the pandemic, we were conducting regular opinion polls. And that enabled us to gauge the concern of the people. They have trust in government. And we will tell them on a scale of 1 to 10, how much do you think federal government is handling this? How much do you trust state government in doing this? So we continue to get figures like maybe 5, 5.5, and so on. And that way, we are able to advise government and what they need to do once we see that this data keeps changing. So trust is an essential ingredient that we need if we want to be successful in our communication interventions. So I'm trying to move to the next slide. I don't know. So, okay. So how do we build a successful communication localization? There are 3 steps mainly, but they are not limited to this, but they are summarized as follows. You analyze, you need to understand your target audience, just like I said. There are various dimensions for analyzing the target audience, but I will be sharing shortly with us the general categories that will enable us understand our target audience. then you choose the right localization approach. There are many approaches. And based on the understanding of the target audience, then we'll be able to choose the right way we want to tailor our messages in such a way that it will resonate with this audience. And the next is we execute our plan and we make sure that we do that effectively. So the first is understanding the audience. Audience is very key. Audience is very important. Without audience, then what we're doing is meaningless. The demography of the audience. Who are they? We need to know our audience in terms of their interest, their age, whether they are married, because somebody who is married and somebody who is not married, they have different priorities, their gender, their occupation, their economy, economic class, socioeconomic class. And that will enable us to categorize to know what are the priorities or the needs, probably what should this audience require in terms of the message or issues we're dealing with. Then the geography is also important because where are they? Are they in the rural areas or urban areas? Their environment also influence and inform their beliefs, their thoughts, and their actions. So are they on social media? It's also important. It's also important to know, are you dealing with audiences in different groups like artisans, professional bodies, and so on and so forth. So all these interplay and to categorize the audience and to enable us segment and the audience with respect to our messaging. Then we need to understand their practices. That talks to the behavior. What is the culture in the community? What do they do with regards to the issue in question, like Lassa fever that we're talking about now? And then what is the compliance journey like? Where are they in the scale of behavior change? Some are level of ignorance. Some are level of awareness. Some are level of being informed. They have deep understanding of what this situation is. The knowledge of the Lassa fever, what causes it, how it is transmitted, how it is prevented. But are they convinced? No. So some people are convinced that yes, Lassa fever is truly a problem and it is caused by contamination of our food with infected urine from rodents and so on and so forth. But some are not convinced. They tell you it's spiritual, it's whatever. Then some are the level of decision making that, oh, I have decided that I'm going to do this. So and so on and so forth. If we understand where are they at the level of decision, are they at the level of taking action, or even maintaining the action is also very important. So our psychography talks about why do they do what they do? And this speaks to the values, which is essence of our existence. The interest, their personality, their preferences, activities they like. Through that, we can gain insight as to how to tailor our messages and our interventions in order to ensure that we optimize their impact in them. So the next slide is talking about how do we choose the right localization approach and what are the options that we have. And these are various options that we have used in all our engagements, be it COVID-19, cerebrospinal meningitis, or Lassa fever, yellow fever. So for the sake of us learning, we know that we may not have used all this in the Lassa fever, but we have the benefits of resources, huge partnership during COVID-19 pandemic to be able to invest and then use many of these. So we can learn from that and see how we can use and transfer these opportunities or these skills, these approaches for preventing Lassa fever in the community. One of them is drama or dance. You will see how we have used that shortly. The local media, that in each community, they have their community reporters, their community media, either radio, print, or online, or broadcast. Then the music is another way that we can facilitate people understanding what we do. And then also graphics. Graphics can give us good illustration, can depict steps, processes, and can depict environment picture, what we want, and it is memorable, we can easily understand. Then the jingles, PSA, proverbs. There are many relevant proverbs that we can apply. And Dr. Fagbemi that presented earlier, when I was in Ondo State in 2019 for Lassa fever response, and I learned so many proverbs from him. and they were very relevant to the context of our response. Then cartoon, comedy skits, and so on. So recently, we just produced a Lassa Fever drama, drama series, that I think we have started hearing them in some states through the support of Breakthrough Action Nigeria, and we hope we will have resources to be able to do it in all states. I'll just play this for just a few. I don't know if people can hear this. Oh, this is, let me see. So I'm playing it, but.
You will have to reshare when you are sharing.
Maybe you drop it in the chat box.
I have to reshare. What do I do?
When you are resharing your screen, there's a small box to the left.
Okay.
Low, it will ask
so
you.
I should stop sharing, right?
Sharing.
Okay.
When you want to reshare.
When I want to reshare now, okay, there's a small button where.
To the left below, it will ask you if you want to add audio also.
I see share sound, right?
Exactly.
Optimize for video clip. Is that what it is? It's sound. So I can click the two.
Yes.
Okay. Okay. Yeah. Thank you, Dr. Lainka. That's teamwork in action. Okay, work. I'm not hearing. It's not working. Anyway, so this is one. Then another one is that I'm going to also play, but this is about COVID-19, the drama that Arewa 24. We work with them. Then are you here?
Yes.
Okay.
يا الله كربا مود شرن أبوك الله كربا مود شرن هو مبابر يا الله كربا مود شرن فرا دنونو كندرمو أما باب زما الله كمان إياه كير إتا فاتها
الحمد لله الحمد لله
إنا زوا أنت ورا واحد اسمه ثلاثة أربعة خمسة كأجنة وتو أنا ذاك تأيا دم جنن ذاك أنا ذاك إن أمسى مك عشان يو بسم الله
تا
إيه
تا
نعم
dama ya Zaidi na zo ne ka dauke ni mu tafi kasuwa tare
ni ba zai yi ba wato kana nufin in dauke ka a babur dina mu rika tafiya mu.
So that is in an Hausa language, part of localization. I mean, we localize the language, but what this one is saying is social distancing or physical distancing during COVID-19, and is declining to carry the man on his bike. Then this is another one I'm playing.
I love you. I want to marry you. I want you.
I want you too. But I had promised not to until after our marriage. I know you wait because you love me.
I love you.
I love you.
I'll wait.
My young girl, love is there for body. This thing they call love, not serious affair. Make you think well before you agree. I beg you, if you love life, you go plan I'm well. Oh yes, man. If you love me, you go wait for me.
Well, some people are already singing and dancing. So, so that's talking about family planning. You can see when people continue to hear these memes recurrently, it hits the depth of their emotion and they are able to. So now, this is another one, local media. I'm going to also quickly play this for us to understand another way we. Okay.
Splendid TV Yoruba.
Ẹ̀yin aráalé, ẹ káàbọ̀ sórí Splendid TV Yorùbá. Ohun tí a fẹ́ gbéyẹ̀wò lónìí ni àwọn orin akọ́mọ ní ìwà nílẹ̀ Yorùbá. Orin akọ́mọ ní ìwà, àwọn orin tí a lè fi bọ́mọdé wí nínú ilé. A máa rí pé kì í ṣe gbogbo ìgbà náà la máa na ọmọ gbà gbòógbò, ṣùgbọ́n ó ní àti a lè fi máa kọ́ àwọn ọmọ wa ní ìwà. Àpẹẹrẹ ni jí koro rí, wẹ̀ kí o mọ́, gé èékánná rẹ, fàṣọ rẹ, jẹun tó dára lásìkò máa jẹun jù jí koro.
Okay, so and we also use cartoon during the COVID-19 that we produce for children to understand. That's
Bubbles! I show up anytime you wash your hands with soap under running water, and you'll see bubbles! Over here, quickly.
Captain Bubbles.
okay. So that is, well, then even the disability are not left out.
I trust that by now you know that the new coronavirus, also known as COVID-19, is real and that it is highly contagious. But do you also know that many people like you and I, young or old...
So, and then we also use comedy.
I dodge Jamo. Obi, what exactly are you dodging? COVID now. You are very funny. Is this how you have been dodging every cough and sneeze?
Yes, my guy. The thing don't serious. Oh.
Have you taken your COVID-19 vaccine?
Leave that matter for Matthias. I have heard plenty things like...
Beggy, I have taken my complete dose of the vaccine, and as you can see, I am okay.
Why you come still dey wear mask?
To protect everyone from getting the virus. It's good to dey practice the protective measures as the vaccine work now to stop you.
Okay.
I trust
that. Those are some of the approaches that have been used for communicating health messages, and we can see how they resonate with community members. Some of them, people laugh over them. So what strategy do we use for implementing this? We don't just sit down and develop these messages as experts or as authorities, but we make sure that we work with the community. For instance, for the hands campaign that we implemented, we created the messages. Then we also adapted messages like from when we work with the religious leaders religious association in the country, Supreme Islamic Council of Affairs and Islamic Affairs, and then CAN, the Christian Association of Nigeria. They came together to form what we call NIFA. What they did was they told us that the messages we were preaching about COVID-19 were messages of fear. So what they wanted, what they can do, what they are used to is messages of hope. So they took our messages, we worked with them, they adapted them to the context that makes it easier for them to preach to people, to talk about COVID-19. Then pre-testing of messages is another way that we also involve the community. Because finally, before we roll out or launch those messages, we make sure that we pre-test them in the community. Advocacy communication targets the policymakers, the community leaders, religious leaders, and so on, to be able to ensure that we elicit the right cooperation from them and the support needed for culture change. And then participatory communication. This can never be overemphasized. Dr. Olayinka went into this in details. So one way to make all this successful is for us to do social listening. Now this is embedded in our infodemic management system. There are many ways we do this: community polling, focus group discussion, key informant interview. To hear from the people, even survey also help us. And then for us to be more practical and more relevant, we use theories. So theories help us to understand the problem, define the problem, and also plan and implement and evaluate the problem. There are various types of theories: social ecological model and a human-centered design in various dimensions, and division of innovation theory and so on. I mean, this is not the time for us to talk about the theory. So what are the benefits? And this is the last slide. This will help us to have improved audience participation and experience. No doubt about that. Some of us who have been involved in message creation, and we own it, we feel we are part of this, and we are also going to be advocating for such conditions. Ensuring fully adapted content for local markets. As in, when we say local markets, our audiences are our markets, and to make sure that whatever we are bringing in, it's fully accepted and it resonates with them, it speaks to their needs, and it also saves time and money. Instead of us printing SBC materials and we send them to the community at the end of the day, and sometimes it could even achieve the opposite effect. It can be counterproductive. Then it provides framework for measuring success. It's easy for us when we have involved the community. We'll be able to understand how they have received it, how wide this have gone, and then what impact it's making, what changes. And then also, of course, communication for structural changes like social determinants of health. So this also goes beyond just direct health risk factors that we're looking at. We also look at issue of provision of water, issue of like climate change and so on. Then overall,
I confirm it's from my end, or so this is network went off.
Dr. Disu.
Okay. I think he was actually at the end of his presentation, so we can safely move on. All right, thank you very much, Dr. Disu, for walking us through this very engaging presentation, and thank you for the great summaries on how to localize our communication, ensuring that we co-create, adapt, pretest, advocate, and ensure that we have a participatory approach to all of this. Great job as usual. Thank you very much. We are now left with 15 minutes on this call, and it's for us to utilize these by addressing the questions that has been raised in the comment section. I mean, the Q&A section, beg your pardon. And to help us coordinate this section, it's my pleasure to invite to join us now, Dr. Oyeladu Okunromade, the head of the Department of Surveillance and Epidemiology at the Nigeria Center for Disease Control and Prevention. Dr. Okunromade, please let's take this forward. Over to you, madam.
Thank you very much, Mr. Biodun, for moderating this, and gratitude to everyone that's been part of this webinar. I'm happy to be joining us on the 4th Lassa Fever webinar series today. I would be your moderator to moderate the Q&A section, and we have a few minutes left. We have a lot of questions, so I'll quickly run through that in two series. The first question here goes to Dr. Fagbemi. Dr. Fagbemi, please, what role did the Ministry of Agri and the vet expert plays in your rat eradication campaign? Was there any form of collaboration in Ondo State? The second question goes to Dr. Olofa. Dr. Olofa, please, in the first presentation, the presenter projected something like 6 states plus 1. I'll need more clarification on that because I always known about 6 states and FCT. And the third question, are there any precedents of decentralized models of care for VHF that can be applied to Lassa fever? That question also goes to Dr. Fagbemi. Dr. Fagbemi, also, what is the role of the veterinary services in the control of Lassa fever? In your strength component of SWOT analysis, the availability of vet services is not mentioned. Why? The fifth question, please, Dr. tell us specifically how you say the supporting community action against Lassa fever. We'll take the first round of questions. After that, we'll go to the second phase. Thank you. Over, please.
So we start with Dr. Fagbemi in 2 minutes, sir.
Dr. Fagbemi, you have 3 questions. 2 minutes. Thank you, and over.
I was confirming earlier on if Dr. Fagbemi.
Okay, I think Dr. Fagbemi. Okay, so we'll go to Dr. Olofa. Dr. Olofa, over to you. Dr. Olofa, your question is on the projected representation on 36 states plus 1 instead of 36 states plus FCT. Just want a clarification on that. Thank you, Anova.
Okay, thank you, Dr. Oyeladu. I don't get the question. Hello? Hello, Dr. Okromadu.
So I believe it's just for clarification. The poster just want to know whether we have 36 states plus FCT or 36 states plus 1, making 37 states. So this is just a kind of a social studies question. What we have is 36 states plus FCT. Over.
Okay. I think we have captured it. The person that asked the question wanted to know what I meant by 36 plus 1 states. So is that the question? 36 states, the plus 1 of it is the FCT, Federal Capital Territory.
Okay, thank you. That's the clarification that is needed. Dr. Olayinka, over to you, madam. Your question is on how you say you're supporting community action against Lassa fever as you presented.
Okay, thank you very much. Although I'd responded in the chat box, for Lassa fever, we need to understand the disease better from the behavior lens. So we're doing what we call the human-centered design approach. Dr. Fagbemi alluded to this. We've done the discovery phase in Ondo, Edo, and Benue.
Dr. Olayinka can increase the volume a bit.
Where we've generated insight, understanding how people perceive the behavior, the risk perception. I can share the insights report for people that want to learn more about this. Specifically also, we've done targeted interventions in selected LGAs in Bauchi State, where our aim is to shift risk perception from reactive to proactive. We've been doing deliberate interventions all through for 18 months. We've currently conducted our program assessment to see how we fared in terms of how were we able to shift risk perception. We've seen that in specific wards that we intervened, we've seen a higher knowledge around signs and symptoms of Lassa fever, and they keep on presenting, so they are more aware. So they present themselves for test. And we've realized that there's a need to shift the communication from signs and symptoms now more to preventive behaviors. We are focusing more exactly what Dr. Fagbemi put out. We are working with environmental health officers. We're also taking forward our design and test phase to look at, there's a whole issue around waste management, there's a whole issue around food storage handling that we are seeing is kind of alluding to more of the cases. So how can we make sure that food that goes from the farm to the table is safe? So that's the focus of our design and test phase for the HCD. We'll be doing that in Ondo and Bauchi. We support the Nigeria Center for Disease Control with developing social and behavior change materials. Dr. Disu mentioned we have a drama, and this has been started broadcasting again as part of preparedness efforts since October. We wanted to change from just telling people what to do, but again, the drama helps people to connect with the story and follows different characters to the end. It's a 12 episode drama that is airing in 6 states, the high burden states. We continue to be part and build capacity across board from community volunteers to WDCs to religious leaders. So the intervention USAID is funding, again, through Breakthrough Action is focused on risk communication and community engagement. We've continued to identify healthcare workers, again, as Dr. Fagbemi wrote it, again, attitude of healthcare workers. We saw that a lot in our, and so we plan to collaborate with IPC, case management. Again, when you're doing trainings, you can bring us in to talk through provider attitude, addressing stigma. And we do a whole lot of community listening, infodemic management related to Lassa fever. So there's a whole lot we do around this space that USAID is working on. Over.
Thank you, Dr. Lainka, for doing justice to that. So riding on that, you have, just hold on a minute. The second question for you, the poster would like to know how monitoring and, if possible, evaluation of such interventions are done. And in community engagement, I believe what you meant to use, you're meant to use community-led Lassa fever eradication while facilitators guide them for an outcome. Again, as communities composition differs, facilitators need to study communities to know best way to engage them for better results. So it's not clear. I think the question here is how monitoring and, if possible, evaluation of such community interventions are done. I think you have just 1 minute to answer this. Thank you, Alova.
So for monitoring and working with WDCs, we did a baseline assessment. And then because the activities they are working on is also facility related, like we said, again, number of children that they supported to get immunized, take for ANC. So we use that. We also have, there's a tool, WDC tool developed by MPHCDA. We work together to review that. We've also done assessment, again, program assessment, and then there's been an external evaluator that's also going to look at the work. But most importantly, when we try to look at intrinsic behavior, we're looking at most significant change now. And so we are currently doing the most significant change approach to see, again, they themselves, do you understand? There's that thing of, yes, you're helping your communities, but have you imbibed that particular behavior as well? So we use both qualitative and quantitative methods to assess to evaluate the intervention. Over.
Thank you very much, Dr. Lainka. I would like to invite Dr. Disu for the next question. What do we do to communities that vehemently refuse to receive these messages, or some families that refuse to key in? Dr. Disu, over to you.
Okay, thank you very much, Director of Surveillance. What do we do to communities that refuse to key in, or the families? Like I said in my presentation, there are stages of behavior change. Maybe because we didn't have time for me to elaborate on that, starting from ignorance to awareness to being informed, being convinced, taking decisions, taking action, and maintaining the action. So there are incentives and a lot of factors that can influence, interplay of factors that determine how you move from one stage to another. So this can be at individual level, this can be at family level, at community level. And that is when I talk about theory, use of theory like socio-ecological models. Socio-ecological models help us to understand the interrelational factors that influence decision-making and behavior change at every level that I've just mentioned, other community, family, and so on, even at the societal level. So for those communities, if you do audience analysis, you will understand why they don't want to do that. If you do your psychographic analysis, what are their values? What are their interests? Is it that their interest is jeopardized? When we do our stakeholder analysis, we understand those whose interest is affected either negatively or positively. They are the stakeholders. Some, they benefit from that problem. Some, they lose from it. Maybe it affects their business. So because of that, they don't want to. The issue of stigma in our community is also another reason why people don't want to be identified with this disease. They don't want to honor because the way people will react to them. We have had cases where, even outside Lassa fever, where people commit suicide just because, like monkeypox, the first case of monkeypox we had not the first case, and I think in Rivers State, and the person committed suicide because of the way people react to them. That is why our strategy was community needs to own when
30 more seconds
in the community. When it is leveraged, then you will see that people will open up and people know that they will be supported. They will not be crucified or castigated for owning up that they have a problem. If it is financial reasons, and then you can get the support, and because our community naturally will come together to help ourselves. So we need to explore a lot of opportunities that the community engagement can give to us. And we need investment and research into community engagement to let us understand how better to optimize community engagement for all our approaches, not just communication, even testing, even surveillance, and then even case management. Thank you very much.
Thank you, Dr. Dito, for that response. Lastly, we have a question here, and good morning and well done to all facilitators. The last outbreak of Lassa fever in Ogun was detected in UTH Ibadan via CSF. Please, how do we report the case since the virus was not detected through blood at the designated laboratory? Okay, I would, I don't think we have a lab person here, so I would like to address this and also invite the IM or the IM to touch base on this. As long as it's Lassa fever and it's been diagnosed and confirmed, whether through blood or through any other sample collected, the onus still lie on the state to report. And these reports will not be done in Oyo State. It will be reported in Ogun State, where the case was detected. And be it that there will now be need to take a second sample in the designated lab for confirmation. So please, Ogun State, kindly know that you are still expected to report this case as a case of a Lassa fever, and further confirmation will also be subjected. The case will be subjected to further confirmation as required. Thank you. The IM, I don't know if you have one or two things to add to this before we round up this session.
All right, thank you so much, Ma. I think everything you said is actually in line. The only thing is, I would just suggest that you contact the state's epidemiologist in Ogun State so that we can follow this up. I know CSF is not one of the regular samples we take, but then this will need to be explored further, and we would like to hear from the state epid so that we can document this properly as well. Thank you so much.
Yeah, thank you. So we've come to the end of our Q&A section. Mr. Biodun, over to you.
Yeah, you're still the one in charge to help us take the closing thoughts and the key take-home messages. Thank you.
Okay, thank you very much, everyone, colleagues, distinguished participants, ladies and gentlemen. Thank you for your time. Draw the curtains on the fourth Lassa fever webinar series, inspired by the wealth of knowledge that we've shared today. I'm inspired by the insight and our collective commitment that we've shared throughout our discussion. Some of the key insights in today's discussion, our theme today, which is empowering community in the fight against Lassa fever, has highlighted some of the strengths, the weaknesses. We've listened to the threats and opportunities available are built to us in building a resilient response system to Lassa fever, as well as some of the local call to actions. Some of these local call to actions include the need for shared responsibilities, such as ensuring deeper engagement with involvement of sociocultural methodology. These also include exploring alternative care, as shared by Dr. Fagbemi, and more importantly, the need to empower the primary healthcare system. This is the first call of the health services available within the community, and also to ensure that we empower the environmental health officers at all levels of the communities in terms of the waste management. And when we're talking about the risk communication, the need for us to intensify the use of social media, and the need to change and adapt our messages to reflect new realities of our communities in combating this health challenge within our system. In closing, I would like to extend our deepest gratitude on behalf of the DG NCDC to all our esteemed panelists Dr. Fagbemi, Director of Public Health, Ondo State, experts in the House, Dr. Olayinka Umar Farouk, the Deputy Project Director from Breakthrough Action, every other distinguished speakers that have generously shared their time, their expertise, their wealth of experience and perspective with us. Your valuable contributions have illuminated the Lassa as a regard the risk communication, has provided us with more tangible strategy to empower communities in the face of this threat. Empowerment, as defined, it's a dynamic process. It involves education, it involves engagement and sustainable intervention. And we've been made to understand that in engaging the communities build trust and credibility so that our messages are accepted and they're able to generate local solutions to some of their local problems, as mentioned by Dr. Olayinka. So it's about ensuring that we incube individuals, incube the communities with the knowledge that they need and the resources they need to protect themselves and protect others so that they can foster a sense of collective responsibility across their demographics. So as we move forward after this webinar series, within our own communities, our own space, let us ensure that we carry the torch of this empowerment with us. Let us amplify our effort to reach every grassroots, ensuring that every community is armed with the knowledge to detect, prevent, and respond to Lassa fever. In closing, I would like to express my gratitude to all participants. Thank you for staying with us at the end of this, all attendees, all our sponsors, the risk comms team, NCDC comms teams, the organizers, the moderators. You've all collectively made this series a resounding success. Together, we're not only raising awareness, but actively we're shaping our future where Lassa fever will no longer be a threat to our community. Thank you for all our collective efforts, and I wish us a very fruitful day. Thank you, and see you next time.
All right, thank you so very much, Dr. Yeladu Okoromari, the head of department. Just a quick announcement that we should please check the chat box, everyone, for the Lassa fever resource materials that have been shared. It can really help us to take this conversation forward. Also that we have NCDC toll-free line. We still have more than 170 participants on the call. We were initially close to 200. Please, 6232 is the NCDC toll-free line. Do well to reach out, do well to engage, and we will continue to wage war against the scourge of Lassa fever. And we believe that in the fight between the organism and human beings will continue to win with our collective resilience and effort. From my side, my name is Biodun Oguni, Assistant Director and Epidemiologist with the Nigeria Center for Disease Control. And it's been my pleasure being your host on this engagement today. See you again some other time on our other webinar series. Do have a very good day ahead. Bye for now.
She better add this one to Tinito. 12, 5, I mean, 3, 3 and 8, 3 and 5.